Hi, this is Don Sharp from OBR, and I want to welcome you today to our webinar. The webinar today is titled Maintaining Your Practice's Financial Health in Uncertain Time. I'm told that I don't have the best reception and there's a little in and out, so I hope you can hear me. But what I'd first like to do today is thank our sponsor, Cardinal Health Specialty Solutions and VitalSource GPO, for allowing this opportunity today for us to learn from real-life healthcare providers, as well as from Cardinal Health Specialty Solutions and VitalSource GPO. Because I am having a little bit of audio difficulty, I'm handing this over to Karen Kellogg right away. And Karen, if you could take over, I know, let me just first state that you are the Director of Practice Consulting at Cardinal Health Specialty Solutions, and I was supposed to have a bigger role here, so I apologize immediately for putting the burden on you. But if you would please, Karen, if you could take it away and maybe share our learning objectives and introduce our faculty too.
Sure, I'd be glad to. Thank you, Don. Yes, we're glad to be here today. Today we have not only myself, but my colleague Helen Manhalter, who is the Senior Product Manager for Technology Solutions at Cardinal Health Specialty Solutions. And then we also have from the practice, the oncology practice side, Dr. William Mitchell, who is CEO and Senior Partner of Southern Oncology Specialists, and Sarah Cohort, who is the Practice Manager for Southern Oncology Specialists. So thank you all for spending time with us today and sharing your experience. Our learning objectives today are, first, we want to ensure that after participating in the discussion, you can identify key challenges that can stand in the way of maintaining the optimal financial health of your practice, even in the best of circumstances. Secondly, we want to provide a better understanding of how uncertain times and events like COVID-19 can impact your financial performance and your financial operations. And finally, we want you to understand some key best practices that you can put into place now to maintain your practice's financial health, even in uncertain periods of disruption. We'll start out today's discussion by sharing a list of some of the most common challenges that stand in the way of financially healthy oncology practices. These are challenges that are faced by practices even in normal or our pre-COVID times. First is the submission of unclean claims, meaning claims that are not paid at the first submission. Claims that are termed unclean can be due to the claim being incorrectly coded, lacking information or NDC numbers, or submitted prior to securing a required pre-authorization. It can sound simple, but the submission of unclean claims is the #1 cause for reimbursement delays and denials. This is key because claim denials mean you're not being reimbursed for services rendered. Delays in reimbursement mean that you're negatively impacting your cash flow, which can make it more difficult for you to free up dollars to invest in the continual improvement of your practice. And worst case scenario, high rates of denied or delayed claims can make basic business operations like maintaining payroll a challenge. Secondly, failing to submit claims in a timely manner is a common pitfall for practices. Industry best practice is to submit a claim usually within 5 days of a service being rendered, and delays in claim submission can be due to a variety of reasons. But failing to document in real time, which is our third challenge, can be a key contributor. Clinicians are extremely busy, and when they don't immediately document a service after it's completed, they tend to forget key details. This can lead to dollars left on the table for services that go unreimbursed or under-reimbursed. A key example of this would be failing to record medication administration in real time, including the billable waste. Oftentimes, the medication dosage that's prescribed by the physician is different than the amount of medication that's provided in the vial by the pharmaceutical manufacturer. So failure to record the medication stop and start times, the total dosage administered to the patient, and the amount of billable waste can lead to a practice bearing financial burden of unused and unbilled portion of that medication. Our fifth challenge is keeping an appropriate amount of inventory on hand. Given the really high cost per dose of cancer medication, This mistake alone can lead to tens or hundreds of thousands of dollars being tied up in inventory. Those are dollars that you can't use to invest in your practice. Our next challenge is either not having access to or not consistently reviewing real-time clinical, financial, and operational data for your practice. If you don't have real-time visibility into all aspects of your practice, you don't have visibility into problems that are or have the potential to be damaging to your financial health. Without the information, problems remain visible. Ensuring a practice is fully and promptly reimbursed for all the services they're rendering. But our final challenge is a little different. It's the failure to explore revenue diversification opportunities. We'll explore this a little later in the presentation. The central point here is that having diversified revenue streams can help financially insulate a practice from threats to other forms of their revenue. So next, let's explore just a handful of the ways that COVID-19 has exacerbated these financial challenges. For context, remember that early and mid-March was when many of the states began to experiencing social distancing, stay-at-home, shelter-in-place, and other orders in an effort to contain the spread of COVID-19. During this time frame, many hospitals, healthcare centers, and private practices also dramatically reduced elective procedures, well-check visits, and other non-urgent medical procedures. While these actions were taken to protect the public health, they also had some unintended consequences on the operations and financial health of medical practices, including oncology practices. First of all, most oncology offices experienced reduced patient visits and reduced new patient referrals as patients in fragile health stayed home, and as many of the routine medical procedures, which would usually result in a new patient referral, were canceled. This reduction in patient visits and referrals for most practices led to a significant reduction in their revenue. And anytime you experience a reduction in revenue, it becomes all the more important to ensure that you're doing everything you can to maximize reimbursement for the services that you are able to render to remain viable and to cover your basic expenses. During this time, many practices implemented new staffing models, some or all of their staff to work from home. Having staff work from home doesn't necessarily mean that a practice won't be able to properly manage their finances. However, in this case, that work from home order came really abruptly. Oncology staff were trying to perform their jobs from home, which was a new working location for them. They were facing more distractions, and in many cases, they were experiencing significant disruptions to their normal daily workflow, including the way they would typically document patient services and submit claims. It's important to note that this abrupt change impacted practices that even in the best of times, even the typical and pre-COVID times, had optimal processes in place for managing their financial operations. The onset of COVID-19 also led to innovation, including the rapid transition to telehealth. When CMS announced that its intent to dramatically increase reimbursement for telehealth services, practices took the time to research, train their providers, and implement telehealth service offerings so that they could continue to serve their patients. However, with these new services came new billing codes and new processes, which initially led to an additional claim errors, denials, and delayed reimbursement. You know, it's understandable to want to stock up during times of crisis, but excessive drug inventory can cause additional strains on finances. Practices that did not utilize just-in-time inventory management systems found themselves carrying the cost of unused medications, which went unutilized due to the fewer patient visits. Given the high cost of oncology medicine, this challenge, coupled with the delays in reimbursement, caused a significant drain on cash flow for some practices. Lastly, when practices were focused on managing the basics, their attention away from the non-essential tasks like technology development, new innovations, and evaluation of opportunities to diversify their revenue. With the notable exception of telehealth, which undoubtedly allowed practices to continue serving their patients, there was little time to be spent on the evaluation and adding of new and alternative services. So let's take just a moment to look at the data. Here we'll share just a few data points to underscore the impact that COVID-19 has had on practices. This is data that we were able to pull from Cardinal Health's Advanced Practice Analytics. We show that new patient volumes are down 26% compared to the beginning of this year and 19% compared to August of last year. You can see also there was a large dip in April that has started to recover, yet we know the impact that has on a practice when new patient referrals are significantly affected by the decrease in diagnostic screenings. The IV treatments this year are down about 17% compared to August of last year, and we did see a dip and then some recovery, but you can still see that we're not back to normal. And lastly, I wanted to call out the average time to submit a claim, which increased a whopping 52 days during the onset of the pandemic from March to June. That increase was staggering. Fortunately, we've seen a great recovery with practices getting back to normal, and right now we're seeing about 16 days as of September. So after setting the stage, I'd like to begin our panel discussion. And in this discussion, we're going to review 5 tenets. We recently submitted a practices can maintain their financial health today and into the future. That is around cash flow and finances. And as I mentioned, today we've invited several experts to have a discussion on these 5 practices to take to improve and maintain a healthy financial aspect in their practice. I'm looking forward to this discussion, and as a reminder, I'll remind you who is with us today. Dr. William Mitchell is a board-certified physician in medical oncology and CEO Senior Partner of Southern Oncology Specialists, a vertically integrated 4-site practice in Charlotte, North Carolina. Dr. Mitchell founded Southern Oncology Specialists in 2010. Also from Southern Oncology Specialists is Sarah Cohart, and she is the practice manager. As the practice manager, she is responsible for the overall operations, development, and success of the practice. And also with us today is Helen Manhalter, who has 25 plus years working with physician office reimbursement in various roles. Helen is currently a senior product manager for VitalSource GPO Dashboard, the regimen analyzer applications, as well as serving as the revenue cycle subject matter expert for advanced practice analytics. Welcome, everyone. As we saw from the data I just shared, practices are experiencing some unusual challenges right now. When challenges arise, it only underscores the need for practices to really have strong financial operations.
Hey,
our
Karen,
first tenet,
one second. Over again, I just want to make a point. Please, you hear me? Free. We're urging interactivity, but feel free to send your questions in through the chat box in the lower left corner of your screen, and we have a team that's fielding questions. Okay, sorry to throw there, Karen. Go ahead.
No, awesome, great point, Don, and you were breaking up a little bit, so I will repeat that. If you do have a question while we're having this discussion, please type that into the chat box, and we'll be monitoring that, and when we're finished the discussion, we'll be able to take some additional questions and answers if we have some time. Thank you. So, Dr. Mitchell, Sarah, Helen, welcome.
Hello, everybody.
Hello. Thank you for having us.
So our first tenet here is avoiding billing backlogs and reimbursement denials by implementing consistent processes. It's super important for a maximum amount of cash flow to be freed up in the practice to cover expenditures, and one way of doing this is to avoid billing backlogs and reimbursement denials. It's important for practices to establish that consistent process, especially in times of crisis like this pandemic. So Dr. Mitchell, to start us out, would you describe at a high level what your practice has experienced during this pandemic and maybe steps or processes you had to implement to safeguard your practice's financial operations?
Absolutely, and thank you for letting me jump on. Actually, instead of being an expert, how about if I just characterize myself as Murphy's Law of your slides? Anything that could go wrong in your slides, our practice had done that before, so this might be a confession more than an expert testimony. But during the COVID, we started thinking worst case scenario, because in my practice, I am not only the physician, I'm also the business manager and also the financial person. So I was able to kind of put on different hats, and so we started thinking about what are we going to do during the COVID, and let's start thinking about worst case scenario. Let's take it from the patient aspect, let's take it from the employee aspect, let's take it from a physician aspect, and let's take it from a business aspect, and let's just say everything goes wrong, what can happen? And so what we did was we started, through the initiation of worst case scenario, we started realizing that during the COVID, we didn't know if we were going to get infected or if the patients were going to get infected, but what happens if someone does, and what process do we do? And the first thing we did was we made sure that all staff was cross-trained, because when someone goes down, someone has to be able to pick up that load, and not only do that load, but also do that process within our practice, because that does indirectly affect patient care, patient process, billing, and reimbursement. So we had to make sure that if one person went down, pardon the expression, someone else could pick up and go. But we also realized it was safer for our patients, it was safer for our staff if we siloed each office. So what we did before the pandemic is I went ahead and added advanced practice providers. We added 3 physician assistants because we were going to need them anyway. So we started defining roles of what they can do initially, and then it kind of morphed into a more independent role for them as well. Not only did we do that, we also implemented remote medicine and telemedicine, because once the restrictions were lifted, we wanted to reassure the patients their safety, but most importantly, still have access to them to be able to continue their care, so there was no drop-off. We knew that our referrals were going to go down because of physicians not able to do procedures because the hospitals were shutting down. There was a stay-at-home mandate from the state, so we had to do some survival in regards to process and business, but most importantly, make sure the patients don't get sick, waiting or concerned about their procedures or anything else that they needed. So we started doing the telemedicine. We cross-trained staff. We used advanced practice providers for chemo teaching, acute visits, and sometimes from routine follow-ups. But the other thing is when we siloed each office, one physician was specific for one office. So physician A had access to patients of office B, C, and D by telemedicine, but if the patient needed to be seen, they could go to that office and be reassured that there was no travel and there was no risk to them. We also knew that if an office got siloed and someone got acutely ill and the office went down, the other offices who were cross-trained were able to pick up that load and also take care of those patients and not see much decreasing in regards to patient volumes, patient treatments, labs, radiology, and outcomes.
Oh, that's awesome. I love the flexibility of that and having, plan B, plan C, as you're trying to maintain that care for patients. So Sarah, from a financial standpoint during this time, were you seeing billing backlogs and reimbursement denials as a problem? And how were you able to stay on top of that if you were?
So we actually more saw a backlog in reimbursement. We did not have that many issues with billing backlogs. But when the payers began working at home and when they reduced their hours, it in turn delayed reimbursement. So we needed to think fast on our feet. And at the beginning of the pandemic, we knew we had to begin closer monitoring of our revenue cycle management and keep our finger on the pulse. And my go-to is the advanced practice analytics from Cardinal Health, and it provides all of the information at my fingertips, and it's a tool set up for us and it sets us up for success. So that is my main go-to, especially during all of this time. I was on that on a daily basis, making sure things were going out as they needed to, what were our denials coming in, where's our reimbursement. That is what I went to on a daily basis and still continue to do.
Wow, that hit on one of our other options too, is using that analytics tool and how often you use it. And it sounds like you were just completely on top of it. Helen, from your experience with revenue cycle management and working with other practices, what do you think the biggest factors are at play for billing backlogs and denials, and how can practices overcome these challenges?
Well, Karen, I think the big problem that the pandemic brought was the introduction of new types of billing, like the telemedicine, telehealth items. And so it really became important for Sarah and her team to be able to acknowledge how to bill that, and then to make sure that they were getting the response back from the payers timely, number one. And number two, to make sure that they were on top of those denials right away, should something not have been billed correctly, if they didn't have the right process, diagnoses, etc. So the key piece in that is really acknowledging the responses back from payers and making sure that they're on top of those as quickly as possible. Because obviously the cleaner that claim that the payer is going to pay, the quicker their reimbursement comes back in, and that just helps them with cash flow.
Right, and we did look at specifically those telehealth claims and saw a huge spike in denials and things like maybe just miscoded in May. So right after the telehealth opportunity began, there was a huge spike in denials, and then we saw it kind of drop off very quickly as practices began to learn how to manage that.
Correct.
So our second tenet is to document services rendered in real time and submit those claims promptly. In my experience, if your practice is going to be in good financial health, you not only need to avoid the billing errors, but billing delays. So a prompt claim submission is essential to receive prompt payment. While it can be tempting to put off this documentation, it's so critical to ensure that every member of the team, including the physicians, commit to a real-time documentation of every patient service that they deliver. Dr. Mitchell, how are you to ensure this real-time documentation happen with your practice, especially among the physicians and those new advanced practice providers and your nursing staff?
I think it's very important because as a physician, I know that not all physicians truly understand the process of which a claim is generated and the service rendered has to be not only documented but also needs to be submitted entirely complete before it's even paid. So once you give a treatment to a patient, the clock starts on the accounts payable in regards to the bill for that treatment. So if you're delaying your time of claims because of documentation, that's only going to affect your cash flow negatively, and by the time that bill comes in, you're still waiting to be paid on that drug that you used on that patient. So in our practice, we've made it a very standard practice that if you're seeing all these patients, you can't be realistically expected for everybody to remember the details 48 to 72 hours after the fact, because otherwise you're just doing the notes. We have a standard one business day, get your notes done completely. That gives you an opportunity that if something happens, you're not able to complete your notes in one day, but at least catch up the next day. That ensures that the billing staff will have the documentation necessary to submit the claim and not hold it pending someone to do their note. We also have, what we have is, it's kind of an incentive, because if you're able to do your documentation, we are able to submit your claim, and if there is reimbursement based on that, that's how it works for your compensation, because it doesn't bother them every 2 weeks when they get paid, but it does bother the company when they're not able to capture that revenue. And most importantly, we also have a revenue cycle management. We've done our billing before, and I can speak on that behalf too, but we have a revenue cycle management company that does our claims, and if the documentation's not there, they have the feedback to come back to us to allow us to know what note needs to be done and how to get that resolved quickly for submission.
That's really fortunate you have that kind of feedback loop. But Sarah, I know you're probably on top of this as well. And how do you keep tabs on monitoring that real-time documentation to avoid submitting that claim later than it needs to be?
So we have many checks and balances in our processes from the front desk all the way to the back with our revenue cycle management company. And as you know, it is not the easiest to stay on top of this daily with every other item that we have to do during the day, but we must make a conscious effort to maintain our financial health. A couple of ways that we monitor is going into the physician's inboxes through the EMR to make sure that they have signed off on the charges, that they have completed their documentation within 24 hours. We also review the nurses' inboxes to verify that all medication reconciliations have been completed with the correct dosage and the waste. It's vital that we capture all drug charges, including waste. Our practice management system is also interfaced with Advanced Practice Analytics, which provides the information that I need to monitor that all drugs, including the waste, are captured. We receive a report daily from our RCM company, and it lets us know if we have any medications that are pulled but are not charged. And after that, we begin our investigation into what happened.
Well, it sounds like you're not only doing real-time documentation, but you're doing a real-time reporting to make sure that all those things are addressed quickly. Helen, from a revenue cycle, just a general revenue cycle standpoint, how critical is that real-time documentation to being reimbursed promptly?
Well, I think as you heard Dr. Mitchell say, AR collection is, the name of the game is time. And so basically these practices have put out a lot of money to take care of patients, and the longer you wait to submit and claim reimbursement back, the bigger effect it has on cash flow, right? So, and the payers all are trying to pay those claims I always like to say as slow as possible. Some of them don't like to be as timely as we would expect. And so the cleaner you make that claim, the better the documentation, the less opportunity you give a payer for them to deny it is going to just benefit the practice. Waiting to submit it just drags out everything. And we saw a big jump for practices that had to, for multiple reasons, were submitting their claims pretty tardy, and that just really affected their cash flow during a time when it, is already difficult with the pandemic.
Right, that huge jump there, and I like the perspective too from the payers that they're probably concerned with their cash flow as well. So
correct.
Just doing this stuff on a really timely daily basis helps avoid those peaks and valleys that you can see in cash flow on all ends. So our third tenet is leveraging integrated analytics platforms to gain full visibility into your financial performance. We all know, whether we like it or not, it takes discipline to monitor financial performance of the practice, but it's absolutely critical to have this clear line of sight at all times into what's driving practice performance and finances, for example, the claim and remit data, and to be able to quickly identify which payers are issuing reimbursements promptly, which aren't, and to diagnose the reasons why. So let's go back to Sarah for a second. As a practice manager, you have to stay very in tune with these practice metrics. You said you look at these things on a daily basis. What are the types of questions you're looking to answer in your analytics platform?
So you are right. It does take discipline on a daily basis. The data is very important in our business, and we must stay on top of our metrics and our trends. And the questions I need answered are we billing for everything that we have dispensed? I cannot say that enough, and we must stay on top of that daily. We also monitor what our drug margins are by our payers, and we do this to ensure that we're receiving what our allowable is and to ensure the medications we are giving are profitable. Another item I look at is what are our outstanding denials. The sooner we can jump on the denials, the more prompt our reimbursement. We also view our days to payment as well as our clean claim percent, and our goal for clean claims is at least 90%. Submitting clean claims means that less time is in accounts receivable, which is less time at the payer, in turn gets us paid faster. With the Advanced Practice Analytics, I can review our denials and our margin analysis, and I can drill down to the specific drug, to the specific patient, and then to investigate the issue. Using an analytics platform has helped me to get to the problems faster, which frees up more time to do other items.
I liked how you said that you have a benchmark for your clean percent. Are there any other benchmarks that you look at on a daily basis so that you know when something gets to a certain level, it's time to really drill down and find out where that problem might be?
Denials. So, we do look at denials to see where they're at. Are we having a problem like when the biosimilars came out? Are we having an issue with the biosimilars? Is it an unlisted code? So that is what I look at also daily, is the denials, to see where they are and if there is a trend to it, to see if we can prevent it from happening again, or do we need to make a change within the practice.
Excellent. Hey, Helen, so from your perspective, why is an integrated analytics platform so important?
Well, I think from a revenue cycle perspective, you can't just look at one angle of it, which is what we used to do, historically, is just the response back from the payer. I claimed something, the payer paid me. What does that look like? What we really need to do, and what we have done, is started to look at the whole process in the sense of following that drug from purchase to dispense to reimbursement, and really looking at what was reimbursed, not what should be reimbursed, is how we used to respond to our physician leadership, is, well, we should be getting X from Aetna. Now we look at integrated systems that will allow us to say to the physician, this is what we are getting. So tying all of those pieces together really allow us to have a better answer back from a business perspective, and obviously back to our leadership team.
Great. So Dr. Mitchell, your practice has proven to be very successful during these challenging times. What advice do you have for other practices, especially for those that might not have resources or the backing of a large organization?
I think the best advice is know your business, because indirectly what you do helps the patient, helps the staff, and then indirectly helps you. And if you know that from beginning to end, and yes, it's hard to talk about financial issues because a lot of physicians get very uncomfortable because they think it runs an ethical line between caring for a patient and looking at the right side of a menu, if you will. But that's not correct, because if you don't start looking at the whole process, you're going to hurt your patients. You're going to hurt your staff because you're going to start having these cash flow issues in which you have to make payroll. They're dependent on you, you're dependent on them, and we're dependent on each other, and that's a very important issue, and that involves partnerships. One of the things historically in regards to billing, crap in is crap out, and if you don't put the information correctly on the front end with information on patients and the exact name and the exact thing, and that makes everything downstream awful. If you don't pre-authorize correctly, anything you do gets tainted. So it's very important to have partnerships with a lot of things, including your staff, knowing what they're doing. There is nothing more frustrating than having a claim sent that gets denied and it doesn't get immediately worked, turned around, and resubmitted, because that is a very serious issue, because that affects your accounts payable, because it doesn't stop the creditors and it doesn't stop the billers from wanting their money. It does affect your cash flow for your ability to pay it. One of the things that's been very hard for me is I've kind of been like a renegade for a long time. I've never really married up with anybody from a distributor standpoint, but I started looking at value addeds, and one of the things that we can do from a company standpoint is to start using value addeds to help make our staff's life easier, to make the process smoother, but most importantly, what we expect is what we get in return in regards to reimbursement. And so it kind of started off with the pharmacy. We're with Cardinal Health because of the value addeds. It's a fantastic GPO distributor for us. Now, it may not be everybody's deal, but at least we know that there's a lot of transparency to help reassure my trust in regards to obtaining our medications. They have resources. They have analytics. For example, the protocol analyzer allows us in real time, when a new treatment comes in, we start breaking it down. We look at the drugs, we look at the admin, we look at the insurance. We break this thing down to its very minute form to know, can we do this treatment or not, because we have to start looking for resources, foundations, external things, or at least the patient's transparency to let them know what they've signed up for in regards to their insurance. And the best way to do it is to start using some of the analytics, like at least for me, it's the protocol analyzer because it looks at the drug specifically. So these are the things that we've been able to work with our patients to allow them their treatments, be able to capture them and use them and allow them to get their treatments in the office, which is high quality, more efficiency, and they want to do that. And most importantly, it makes the staff's job easier in regards to process and reimbursement.
You know, I'm thinking, Dr. Mitchell, another positive aspect of GPO partnership would be your ability to network with other practices that are similar. Have you found that you've been networking with other practices during this time to share best practices?
Oh, absolutely, and that's a great point, and thank you for bringing that up, because one of the things that's very good is when you think, you know, you're in the middle of everything and you're taking care of patients, and you really don't know how another practice is doing, or maybe how do I compare to others, not so much am I better than them or not, what do they know and what do they know, and these are the opportunities that you have through a good partnership, is that you're able to talk to other practices, and that's probably how we've been able to progress in such a short time, is by knowing, you know, you kind of look at the good practices that you think are good, you start asking them questions, and then you start exchanging if you will, some advice for each other, and that's how you grow quick, and that's also how you keep minimizing the damage that can happen to your company.
Great insight. So let's move on to our fourth tenet, which is to optimize your medication inventory to reduce waste. We talked about waste a little bit before, but this is another animal in maintaining all of the drug that is on your shelf. It's a huge one to avoid potential loss of reimbursement given the high cost of all of these medications. Most practices can't afford to cover or float the cost of unused medications. For this one, let's go back to Sarah first to weigh in. Sarah, what types of processes and systems do you use and have in place to manage inventory and to reduce waste?
So we manage our inventory using the inventory management system with Cardinal. This system provides real-time tracking of inventory, and it also provides reporting features. If every medication that's in your inventory management system, If every medication is in your inventory management system, you can significantly improve your charge capture for every medication and use it for tracking available waste. If that system requires you to bill it to a specific patient, it's far less likely that you unnecessarily eat the cost of any medication. A couple of reports that we use is an unused inventory report. This report shows me all medications that haven't been used within my specified date range, which can vary between 30 to 60 days. And another report we use is an adjustment inquiry. This shows me if we've adjusted any medications due to expiration or general waste that was not captured. I'm also able to view all daily inventory at all 4 locations. And we also have our EMR is interfaced with Cardinal, so we are able to see what needs to be ordered. We order 2 times a week to keep our inventory tight, and that has helped significantly with the interface because it helps the farm techs be able to order and know exactly what doses are coming.
Well, that's what we talk about when we say real-time ordering, where you look at your EMR, you see what doses are going to be needed, and those are the drugs that you order, so you don't have excessive stock sitting on your shelf and causing, like we mentioned before, those peaks and valleys in cash flow. Thank you, Sarah. But Dr. Mitchell, from your perspective, how does the inventory impact the practice cash flow?
Oh, wow. It affects it so much. I'm going to kind of have a regression of my days in my youth when I used to work at Wendy's. And when a shipment would come in, we'd have to put the food into the storage. And one day, someone did not rotate the stock, and in the corner, and you think of it with hamburger, it spoiled. And when it spoiled, it stunk. And so that's kind of the analogy I use for the stock of our drugs, because unfortunately these medications are extremely expensive, and the rule is 10 to 1. If you have a drug that is allowed to expire and it's not utilized, or at least it's not given somewhere else, or at least you work with it, you have to do 10 of the same treatments to get that loss of revenue back into the drug that you lost, and it's a very easily avoidable complication of your business. I remember one day back in our early years, and we had somebody let 3 vials of Velcade basically expire, and everybody here is eating Tums and drinking Maalox and understanding how that indirectly affects the bottom line. So one of the things we've been able to do through our integration is we have a pharmacist who's working in conjunction with our pharmacy techs, and as Sarah has alluded to very, very well, is that we are keeping an eye on our inventory, because that is the highest expense of any company, is your medications. And if you don't have control of your medications, then you're going to have a lot of loss of revenue or potential. So we rotate the stock. We say if a drug is getting close to expiration, can it be utilized in another office? So that's where the communication has to be between office A, B, C, and D. And if someone has a drug that says, hey, I can't use this, can anybody use this, then we move it around and we keep track of that. That's a very important issue. The other thing is that with the ordering, we do run reports. We look at what drugs are needed for the patients, and we're able to order them exactly. So that allows our staff to match things up when it comes to billing, so what drug was pulled, what drug was used, and how it was billed. And if the waste does not add up, then they go back and look at what was pulled from our inventory. So that's how we're able to minimize our waste, or at least minimize our damage from not calculating the dosage correctly.
Well, I'm thinking back. Oh, go ahead, Sarah.
Okay, so I do want to tell the practices that are listening, don't assume that the staff do understand how to rotate stock, because that has happened with us before. So definitely make sure that they understand the reasons why and that they know how to do it.
If I can also add too, Sarah, I think the one day that you and I went to each office and just pulled all the drugs off to see just what was in the inventory, it's amazing how much you have on the shelf that you're not using. And the thing is, you don't order it and have it on hold. You order it when you need it. But it's interesting, if you do that exercise just to pull off how much you have sitting on the shelf, it might scare you, but it might also motivate you to know.
Yeah. That's true. Monitoring that, and it can be a huge one-time savings, and then the challenge is to make sure that you keep on top of that. I'm thinking back on our discussion about the integrated analytics platform, and Sarah, your ability to look at things from purchase to utilization to documentation to submitting the claim, managing denials, and all the way to reimbursement, and really closing that revenue cycle loop. Do you have anything else to add in regards to how that inventory plays into that whole revenue cycle?
Other than that is the most important piece of our practice as well. Like Dr. Mitchell said, it is the largest piece of our financials. It's money in, money out, and it's something that you have to watch constantly.
Thank you, Sarah. We'll move on to our last tenet here, which is evaluating opportunities to diversify sources of revenue. We know how important it is to continue to evaluate your practice because it's evolving, especially given this competitive, high-pressured, and constantly changing environment of healthcare. Dr. Mitchell, you've mentioned before that your practice is vertically integrated. So what does that exactly mean, and how do you see it benefiting your patients? What type of services did you add before the pandemic, and maybe how have you had to adapt those services during?
I think vertical integration is nothing more than survival in a private practice environment. We're currently in Charlotte, North Carolina, which is in the middle of two competing hospital systems that have consolidated a lot of oncology practices. So what we did 10 years ago in an effort to survive actually became vertical integration to my ignorance. I started thinking about, in regards to survival, if new patients were becoming decreased in number, how will our practice survive in regards to private practice? So then I started thinking about, as a physician, what was I able to do in regards to services for a patient in their care, and how can I internalize those services within my practice in an effort to help the patient create a good product, if you will, service line, but most importantly, benefit from it from a revenue standpoint. And that's how vertical integration became what it is. So we added a full lab. We have the ability to do a lot of things. We're a high complex CLIA lab. We're able to do flow cytometry from a technical component. We added radiology with 2 CT scans. And the most importantly, and this is probably why, and Stephanie, if you're listening, thank you, we were able to put a pharmacy in. One of the things we were looking at earlier in our progress is, should we do pharmacy or not? And there's different types of pharmacies. There's physician dispensing, there's on-site retail, and then we are closed-door retail, site-specific. So we're a site of care, dispensing. So one of the things is we started talking with distributors, and we talked to one distributor, and they said, oh, you don't do enough prescriptions. It's not really worth your time. And that was 2 years too late for me, because when I finally realized that that was a very important part of our practice and probably the most vital part, it kind of set us back about 2 years, and that is probably one of the worst pieces of advice I've ever been given. So if you can do it, utilize your pharmacy, expand it, and do those things, because you are able to do a lot of things for your patients that you normally couldn't do. Essentially, with our pharmacy, we're able to treat Medicaid within the office with single-source drugs that we normally would not be able to do, and they'd have to go to the hospital. So from a value-based standpoint, especially if you're doing value-based contracting, vertical integration is vital, because you not only benefit from the services you're doing for the patient benefits from the lower cost of care, the higher delivery of service, the better efficiency, and the higher satisfaction, and it's been shown over and over. So that's what we've been able to do through vertical integration. Now, because of the pandemic, a lot of patients were kind of hesitant about their treatments. And if you look at a lot of the national programs, a lot of the physicians, if you will, these experts in some diseases, were actually trying to push their patients over to oral medications. Well, if you don't have an on-site pharmacy, if you don't have physician dispensing, some of those patients would not want their treatments, and if you couldn't flip them over to an oral regimen to at least either tie them off or at least be able to take care of them, that patient would suffer indirectly or have to go to an alternative site, which increases the cost of care. So the pandemic kind of affected us in regards to flow, but it didn't affect us in regards to service. And that was because of vertical integration. So we've been very fortunate enough that during the pandemic, our patients were not able to receive external services from consults and procedures, but indirectly through their treatments, we didn't see much drop at all.
Wow, that's excellent. It kind of demonstrates how those additional service lines can help insulate your practice from maybe a hit to another service line. So Sarah,
right.
What has the go ahead, I'm sorry.
I'm sorry. The thing I wanted to add to that is, when you don't have those service lines, you have to rely on somebody else to perform those services. For example, if you're sending your scans to the hospital, you have now increased the cost of their care, and if someone is on a deductible or has to pay that, indirectly you could do 10 scans through your office versus one in the hospital. The treatments are 5 times more expensive in the hospital, so from a value-based standpoint, you're technically costing the patients more for the same. And I'm sorry to interrupt.
No, thank you. Great point. So Sarah was going to ask you about the dispensing program and what it's meant to your practice over time, and are there ways that you monitor that as well to ensure that it's successful?
Yes, so where do I begin with our pharmacy? It means a lot to our practice. With our pharmacy, it's given us a different avenue to be able to serve our patients. and we've seen a positive impact with medication adherence as well. Stephanie Mayfield, our practice consultant with Cardinal, was and continues to be instrumental in ensuring we are successful. She has set up care plan processes through our pharmacy point of service system. She also meets with us quarterly and reviews and compares the drug classes, which helps us in making decisions. Adding the pharmacy to our in-house services has been a profitable revenue stream, and it's one of the best things that we've done for the patients and our company.
Wow, sounds like a huge amount of patient satisfaction there. Helen, so from a revenue cycle standpoint, we talked a little bit about the IVs and how you manage that with the denials, but the pharmacy is a little bit different. How can practices use analytics or an integrated platform to evaluate opportunities within their dispensing program?
Well, and I think that's what we called out earlier from an integration perspective. With the pharmacy dispensing program, we're able to track that in the analytics view as well. So Dr. Mitchell and Sarah can not only see what their IV reimbursement looks like, but what the orals or their physician dispensing program looks like as well. But we also have, from a diagnosis perspective, the information available. So really, when you assess, what should the practice be doing, what additional revenue stream can we have, it's really important to just look at data and look at the kinds of patients you're treating. Will that even be viable for us? Do we have the need to have that service for our patients? And being able to look at what you're buying, the types of patients you're seeing, the types of tests you're running, I think really gives that practice the ability to know where they should move forward, with sort of decision making on what additional revenue streams can help their practice.
Wow, so we can look at data also, from a retrospective point of view on what has happened, but also looking prospectively to evaluate maybe future opportunities.
Right.
That's an excellent point. So as part of, I serve as a practice consultant for VitalSource TPO, and as I work with practices in looking at these opportunities, we really take them through that complete discovery phase where we look at pro forma research, we help them understand the return on investment. We say, what is this going to look like now? What is it going to look like maybe several years down the road? And at times the decision whether or not to implement some of these expanded services depends on what the practice goals are. But really in this diversified set of services can really prove to be helpful, and especially through times of crisis, to be able to spread those revenue streams out and survive the pandemic. Well, we do have a few minutes left. It's time for the discussion. Thank you so much, Dr. Mitchell and Sarah and Helen, for sharing your thoughts with us today. It's been great to have this opportunity to really go through your best practices and appreciate your insights and experiences. So thank you very much for sharing them today. Don, if you are able to connect, I'll turn that back over to you for some open question and answer from the audience. Otherwise, I'm glad to take that on.
Sure. Well, can you hear me okay, Karen?
I can.
Okay. Well, let's give it a shot, because what I want to do, I mean, it was a great discussion, but what I think we should do is look forward a little bit. Maybe I'll ask you, Karen and Helen, what are some of the changes that we can anticipate in the future and that we should be prepared for as they impact or might impact the revenue cycle? You have any thoughts on that?
Helen, you want to go first? What are you seeing?
Yeah, so when we think about changes, primarily it's going to be value-based care opportunities, right, and how we're going to report from an analytics perspective back to those practices to understand sort of the whole picture of that per month payment that they're going to be getting. So from an analytics perspective, we're taking a look at the best way to report that back to practices, as well as being able to alert practices to issues in their revenue cycle versus just providing reports and having that person or revenue cycle team look for their issues. We're going to try to find those issues before they even happen and maybe alert those practices to that.
I think from my perspective,
Go, Karen.
I think from my perspective, Don, one of the most soon challenges that we might see is this potential surge of new patients coming into the practice. We've talked about maybe the decline in these new patient diagnoses, and there's a thought that perhaps in the next few months that we'll be seeing a surge of new patients that are now getting diagnosed and might have more of an advanced disease than they would have had 3 or 4 months ago. So being able to accept those patients in and get them diagnosed, and maybe it would require additional services to manage more advanced disease. We're also seeing this, the whole way healthcare question now. We've seen increase in telehealth. There's been talk about what oncology treatments or services can be done at the home setting. And also from some practices, I serve the Western United States. So what I'm hearing in the Western U.S. is payers starting to revisit this idea of white bagging, where the drugs are coming from their vertically integrated specialty pharmacy instead of allowing the oncologist to buy the medication, administer the medication, and bill it. So I think those are things just to keep in the back of your mind and follow them, because they can definitely cause some disruptions in your workflow.
Well, I'm going to seize on, yes, that's the most important thing we've heard about, but I'm going to seize on that surge. And, your chart showed a little bit of, a dip and then a plateau. And so I guess, looking forward, we're anticipating the surge. I've heard a lot of physicians and healthcare providers talk about that surge. And I'll ask you, both Sarah and Dr. Mitchell, what are you doing to prepare for that surge? Do you think it's going to happen? And what are you doing to get ready for it? And specifically, I think it probably has to do with staffing models. And how has your staffing changed through the pandemic, and what's your staffing plan going forward, anticipating the surge? Sarah, Dr. Mitchell?
I think the biggest thing is there is going to be a surge because the physicians who normally would refer to us, our oncology patients, were kind of shut down and not able to utilize the hospital for their procedures. So there has been a lag. I do think there has been a shift in stage because of the delay. I don't know how much that would be. I think it's going to be probably smaller than we emotionally feel. But we have a process in place in which we have a dedicated front desk person who will take all incoming new patients and immediately get them in with a physician within 24 hours. And that's been our normal process, is to get someone seen within 24, because if you, especially in our environment, if it's 7 days, 2 weeks, unless it's patient requested, they have time to think, they have time to speak with their friends, go to church, or whatever, and then they're going to get different opinions of things, and they have time to think. So that is a potential opportunity loss. So we try to get them in, get the process rolling, and get them to at least be engaged with us so we can work them through their process.
That sound about right, Sarah?
That sounds exactly right. And like we've said again, cross-training is so important to have across your staff. If someone goes out, someone needs to know how to do, for example, the lab. The person that maintains the lab, we have to have another medical assistant that at least knows what she's doing in there to get us through that day to be able to take care of all of our patients.
Yeah. And, Helen, I'm going to put the spotlight on you for one last question, and really that is about, it's one thing for the healthcare providers to get ready for a surge and to try to anticipate the future. What about a service company like Cardinal Health Specialty Solutions and Vital Source GPO? How do you anticipate things changing, especially, everybody wants to apply new technology? Do you have any thoughts on the future, Helen?
Well, I think that which is what we've been trying to prepare for, right? Which is providing solutions to practices so that the surge or what they see as increased volume, that we're providing tools to help them manage that and be able to see results quickly or see issues quickly, et cetera. And like I spoke to a little earlier before, being able to sort of warn them when things could potentially be an issue. So I think from a technology perspective, we've got a lot of ideas that we're talking through on how to better support practices so that they spend time taking care of patients and not doing the business side of practice management, that we try to take some of that burden off of them a little bit.
Yeah. Well, and it seems we went a little bit over in our time allotted, and I have a couple things. I just want to mostly thank our audience for participating and listening, and I hope we achieve those learning objectives. And I also want to just, as a follow-up, I want you to know that, this isn't over. If you would like to contact us, my email address is don@obroncology.com, and I can triage and forward emails. So if you have any further questions for our faculty, so thank you for your participation, but also a big thank you to our faculty. So very much appreciate your moderation, Karen, and your participation, Sarah, Dr. Mitchell, Helen. And I think we'll sign off with one more thank you to the Cardinal Health Specialty Solutions Group and Vital Source GPO Group for putting this together and allowing us to learn today. Okay?
Thank you, Don. Our pleasure.
Thank you.
Okay. Thank you for your time.
Thank you, Don.